Good morning, good afternoon, good evening. Welcome to the 2025 ESMO Non-Small Cell Lung Cancer Progress Highlights. It is my pleasure to welcome my distinguished panel members. To my left, we have Dr. Helena Yu, who is an attending physician at Memorial Sloan Kettering. To my second left is Dr. Ignatius Wu, who is a professor of medicine in thoracic oncology at the University of California, Irvine. And to my right is Dr. David Perez, who is a medical oncologist, clinical development program lead for Bristol Myers Squibb of the iza-bren program. My name is Jonathan Cheng, and I am the Chief Medical Officer of SystImmune. I look forward to a very exciting program so that we can be able to learn the latest progress in lung cancer at this year's ESMO in Berlin. I will pass on to Dr. Helena Yu for her to give her oral presentation for us to be able to learn from.
Great. Thank you so much for having me. Thank you so much for having me. Today I'll be discussing the Phase 1 global study of iza-bren, BLB01D1, an EGFR HER3 bispecific antibody-drug conjugate in patients with metastatic non-small cell lung cancer and other solid tumors. Here are my disclosures. So iza-bren is a first-in-class ADC comprised of an EGFR HER3 bispecific antibody conjugated to a novel topoisomerase payload by a cleavable linker. This is the first report of safety and efficacy results of the dose escalation and dose finding phase from this global Phase 1 study. iza-bren was granted breakthrough designation by the US FDA for patients with previously treated EGFR mutant non-small cell lung cancer based on the data from China and this study. In regards to study design, patients with metastatic non-small cell lung cancer and other metastatic solid tumors were enrolled that had measurable disease per RECIST version 1.1. You can see here that escalating doses of BLB01 were utilized, and there were 2 different dosing schedules that were utilized as well. Dose escalation was followed by dose finding, where further doses were assessed, and now we're at dose expansion, where there are several doses being assessed at the day 1, day 8 Q3 week schedule. In regards to endpoints, the primary endpoint was safety. Secondary endpoints were pharmacokinetics as well as efficacy, and exploratory endpoints include biomarker analysis. In regards to baseline characteristics, to date 107 patients have been enrolled onto the study. You can see that the study patients were heavily pretreated, with the vast majority having 3 lines or greater of therapy prior to study enrollment. A minority of patients also had prior topo-1 ADCs, and the largest portion or cohort of patients had non-small cell lung cancer, with about half having EGFR mutant lung cancer and half with EGFR wild-type cancer. Patients also had small cell lung cancer, breast cancer, esophageal adenocarcinoma, nasopharyngeal carcinoma, and head and neck cancer. In regards to treatment-related AEs, the most significant treatment-related AEs were cytopenias, specifically neutropenia and anemia. Hematologic AEs were effectively managed by standard medical measures, and treatment-related AEs led to a dose reduction in 27.1% of cases, but led to treatment discontinuation only in 1.9% of cases. Neutropenic fever was present at 5.6%. In the initial dose escalation and dose finding, patients did not receive primary G-CSF prophylaxis. There was 1 patient during that time period that had primary G-CSF prophylaxis. Primary G-CSF prophylaxis has been implemented in the ongoing dose expansion phase of the study. There was no interstitial lung disease observed, and there were no new safety signals that were observed. In regards to efficacy, here you can see the 63 patients that were treated with escalating doses of iza-bren at the day 1, day 8 Q3 week schedule. If you look at all patients treated, the overall response rate That confirmed overall response rate was about 35%, with a median progression-free survival of 4.5 months. When focusing on the red box at the 2.5 mg per kg, treated at the dose level that is being moved forward for the dose expansion, the confirmed overall response rate was 55%, with a median PFS of 5.4 months. In regards to efficacy specifically in non-small cell lung cancer, the top shows the patients with EGFR mutant lung cancer that were enrolled, and then the blue box on the bottom illustrates the patients with EGFR wild-type non-small cell lung cancer. When looking at the total patients treated, the confirmed overall response rate in the EGFR mutant population was 23%, and when looking at the 2.5 mg per kg dosing, the confirmed response rate was 30%. For EGFR wild-type non-small cell lung cancer, the confirmed overall response rate was 40% for all comers, but at 2.5 mg per kg, the confirmed response rate was 75%, although there were small numbers treated at that dose level. So in conclusion, iza-bren has demonstrated encouraging efficacy with a manageable safety profile in heavily pretreated patients across multiple tumor types, including non-small cell lung cancer, both EGFR mutant and EGFR wild type, in this first report of a global population, which is generally consistent with the strong efficacy previously reported in Chinese patients. Primary G-CSF prophylaxis has been implemented in the dose expansion phase of the US Lung 101 study and global registrational studies. There are global registration studies ongoing in the first-line setting for metastatic triple-negative breast cancer, in the second-line setting for EGFR mutant non-small cell lung cancer, and in the second-line setting for metastatic urothelial carcinoma. For acknowledgements, we'd like to thank the patients and their families for their participation in the clinical trial, as well as the investigators and study staff for their contributions to the study.
Thank you so much, Helena. That was a really exciting presentation. The first presentation of a Western population for a first-in-class bispecific antibody. So just for our audience, can you maybe summarize what you consider to be the take-home message from all the data that you presented, and what they should learn from particularly in lung cancer?
Yes, I think that this presentation was anticipated by many. We've seen earlier data from China, both in this setting but in other settings as well. So I think one thing that I'd like to say is that the efficacy and safety data really were consistent with the previous reports from the Chinese data. I think the second thing is that initially G-CSF prophylaxis was not utilized. As you all know, neutropenia really is a lab-based abnormality. Patients come into clinic feeling okay, but I do think that for the dose expansion cohort, being able to use G-CSF prophylaxis to prevent neutropenia will keep patients better on schedule and sort of maintain dosing schedule. And so I think we're all excited about using iza-bren and these additional studies looking at activity in these different cohorts.
Sure. No, and thank you for those important points. Maybe I can ask Ignatius, you are a thoracic oncology expert in medical oncology. Maybe you could share your perspective on the data that was just presented by Helena?
Yeah, so thank you for the invitation. It's very exciting results and a very novel compound with bispecific targets, a novel payload, and as Dr. Yu mentioned, myelosuppression is the only side effects which you can manage very easily as a medical oncologist, especially with the G-CSF support. Dr. Yu also mentioned that we have not seen any evidence of interstitial lung disease, which may distinguish iza-bren from other ADC, which is being investigated, at least for our interest, the EGFR mutated lung cancer. Sure. So it's very exciting data. And also it's also very active in non-mutated EGFR wild-type non-small cell lung cancer. So that's another possibility of a treatment for this compound.
Sure, opens another avenue for investigation. Yes. So David, maybe I can ask you, as the development lead at Bristol Myers Squibb for iza-bren. I'd be interested in your perspective as to this interesting data presentation.
I want to echo what Dr. Yu, what Helena was sharing before. I think that there was a clear need to demonstrate that the safety profile and that the encouraging efficacy that we have seen with iza-bren coming from China could be validated outside China, and that is precisely what I think has been done today. Thanks to your presentation, Dr. Yu, because the encouraging efficacy that we have seen with a confirmed response rate of 55%, with a manageable safety profile, because as you said, let's not forget that these patients have not received primary prophylaxis with GCSF. We are demonstrating consistency with this asset. So basically, the data that we have seen in China today has been validated in a cohort, in a Western patient population. So hopefully we will continue to develop this asset and continue to demonstrate the potential this drug has to change the different landscapes across indications.
Sure. So, Helena, maybe I can ask you kind of the next question is, at Memorial Sloan Kettering, you do a number of trials in lung cancer, particularly your area of research. And so there are a large number of trials that thankfully have been explored in lung cancer because we want to improve patient outcomes. I'd be interested in, from your perspective, the future landscape. There's a number of ADCs that have been explored with varying results. So how do you view the roles of ADC in particular in the lung cancer space?
Yeah, I think that this is sort of the wave of ADCs as treatments for non-small cell lung cancer. We still don't have a non-small cell at large approval, for all patients. I think we have some biomarker-directed, both MET and HER2 ADCs, which are helpful, but are helpful for a small portion. And then for EGFR mutant lung cancer, we have the recent datopotamab deruxtecan, the TROP2 ADC. I think that there's going to be a few things. I think we're going to need to see efficacy across all of these different ADCs. I think it seems like efficacy is somewhere between 30 and 45% for many of them. So I think it will also be CNS efficacy and tolerability, right? That will help us distinguish which of these ADCs we might want to use first for a given patient. And then biomarkers. I think, it's still up in the air whether biomarkers are going to be helpful in helping us select one ADC over the other, but the more options we have, the more there is that need to sort of figure out for this given patient right here, which ADC might be the best for that given person.
Of course, biomarkers can be critical in how we think about trying to match the right patient with the right treatment. Ignatius, similar questions. In the lung field, you've seen the progression across many modalities, from chemotherapy to IO to ADCs. What is your view on the evolving future landscape and the roles of ADCs in this space as it continues to enter into the lung cancer clinics?
Yeah, so as Dr. Yu has mentioned, I think it's very exciting to have a lot of ADCs in the field. We only have one so far approved for only EGFR mutated non-small cell lung cancer. It's the non-small cell lung cancer at large. We still don't have an ADC approved. We are behind in this situation compared to breast cancer and even the bladder cancer. I work with my colleague next to me, and she has so many ADCs to work with. And I think Dr. Yu also mentioned about safety, and so this is important to distinguish the future, all the ADCs. Safety will be an issue, especially if we are treating lung cancer with ADC. The incidence of institution pneumonitis may be important, and so iza-bren does, at least so far, does not have any reported incidence of ILD, and I think that may be very important. And of course, with BMS joining the development, that's important too. You need a lot of resources in the future to conduct a global randomized phase 3 trial to get approval.
Yeah, absolutely.
Yeah.
And maybe delving a little bit more into the ADC question. There have been a number of ADCs explored in lung cancer specifically. Whether you mentioned TROP2, HER3, but this is a bispecific ADC with EGFR, which maybe is a little bit less understood or less explored. So how do you view this, from a drug development perspective, the distinctness of iza-bren, or how you view the different ADC antigens that they're targeting?
It's a fantastic moment to be working in the ADC field, because as you said, John, there's a lot of a lot of different targets that different companies are exploring or evaluating, different payloads, different architectures for the different ADCs that are currently under development. I mean, of course, when we speak about TROP2 is a very well established and clearly understood target that is highly expressed across a huge variety of solid tumors, and there are multiple TROP2 ADCs already, if not approved. Some of them are under development or about to read out positive studies. In terms of HER3, we know that HER3 is a protein that is involved in the mechanisms of resistance for EGFR TKIs, but some of them have not been able to demonstrate encouraging efficacy. And I think that iza-bren has this certain uniqueness or certain particularity because of bispecificity. I mean, we know the role of HER3 and we know the role of EGFR, which is also highly expressed across multiple solid tumors and is able to internalize the ADC after binding to EGFR and HER3. So hopefully this drug might be able to overcome even deeper the resistance after a treatment with EGFR TKI and hopefully other therapies as well.
Sure. Helena, maybe a similar question. Even in today's presentation session, there was other targets. Your thoughts on kind of how you think about the different targets as well as monospecific versus bispecific?
Yeah, I mean, I would like to add to what David said. I think the bispecific modality is just more specific to the cancer cell, right? Because we think that HER3 and EGFR are relevantly expressed on the cell surface of the cancer cells. I think that, there's different ways to select patients. I think we're going to talk about biomarkers. We can look at protein expression based on IHC, but I think picking certain select populations is also biomarker selecting. So I think one focus of some of these ADCs has been EGFR mutant lung cancer, and so I think that is a relevant kind of biomarker selected population because we know HER3 and EGFR are expressed highly in those tumors. And so I think some of the different subgroups that are going forward in development with iza-bren, they're focused on where we see activity, but that activity is kind of associated with where we see the expression of the antigen, right?
Sure, understood. And maybe we can think a little bit more into the biology of lung cancer. So obviously we talked a little bit about, and the data we presented had both EGFR mutant and EGFR wild type. Ignatius, I'd be interested in your thoughts, like how do you view kind of the differences between EGFR mutant and EGFR wild type as to choice of ADC? Obviously we talked about an approval in ADC of an EGFR mutant, but obviously EGFR wild type is very, very important to us and has some of these antigens. So how do you think about that biology of choosing EGFR mutant versus EGFR wild type biology and how you kind of distinguish ADCs?
Oh, that's a
I only ask
very, very in-depth questions. So let me. I think I make a mistake in saying that there's only Dapto-DXd is the only one ADC approved for lung cancer. Actually, trastuzumab deruxtecan is also approved for HER2 non-small cell lung cancer. Yeah, attribute to my jet lag in Berlin, but
we knew what you meant.
I think it's most important is the wild type. EGFR wild type non-small cell lung cancer should also express EGFR protein, and that's looking back more than 20 years ago. The reason why we developed EGFR TKI is because of EGFR protein expression. The higher the protein expression, the poorer the patient's outcome is, and that's why we don't have a biomarker at that point. We don't have an EGFR mutation testing, and we just develop an EGFR TKI just based on the biology of EGFR protein expression. That's why it's very exciting, and hopefully that iza-bren will also be able to target EGFR wild type non-small cell lung cancer, because there should be a high level expression of EGFR protein, and HER3 is partner to the EGFR signaling pathway. And also, Dr. Yu was the PI for the Helena Lung 01 study, and we were very excited that because this is part of the signaling pathway for EGFR signaling, and it turns out for the Helena lung 02, there was no overall survival benefit. It's pointing that it's even more important to target not just HER3, but also EGFR HER3 together. That's more, that is even more critical now that we know the results.
Sure, completely understand. As you know, as a drug developer, EGFR mutant has a different standard of care with TKIs versus EGFR wild type. So your thoughts on how you view EGFR mutant versus wild type, particularly for ADCs, and how you might distinguish them based on the data known so far?
I think it is important precisely to let the data inform us the ADC to utilize in the clinic, right? The one that we need to prescribe. And based on what Dr. Yu has shared today, we have seen a really compelling efficacy also in the EGFR mutant space, but also in the wild type space. In EGFR mutant, the confirmed response rate was 30%, but let's not forget that this patient was extremely pretreated with even up to 9 prior lines of therapy for some of these patients. And in the wild type space, we saw, and you shared with us today, Dr. Yu, a response rate that is 75%. It is true that the sample size was small, but hopefully these numbers might hold. And if they hold over time, we may have a potential practice change in ADC here. So hopefully we will need to generate, of course, more data to continue to validate these results.
Yeah, look forward to more data. If I could just transition a little bit to side effects. Because we all know that with efficacy, there is the potential for side effects. So I know, Helena, you've enrolled a large number of patients and have treated them with iza-bren. I'd be interested in your experience with the side effects as well as how you might manage them.
Yeah, I think that there are certain class effect toxicities, right? I think all of these ADCs have a chemotherapy payload, so I think we're seeing cytopenias with a lot of these, and that was one of the more striking, I think, toxicities with iza-bren. I think these are lab-based toxicities mostly, where I can't tell when somebody walks into my clinic that they have this issue, but of course we find it on the lab, and we want to prevent neutropenic fever and other kind of more life-threatening issues. But I think that the lack of prophylactic G-CSF kind of obviously led to those numbers, but as you know, Jonathan, in the expansion, we're doing primary G-CSF prophylaxis for all patients, and I think that there's a provider comfort with that because we do that with platinum-based chemotherapies and other agents, and so I do think that's going to mitigate that toxicity significantly, and I think allow us to stay more on schedule for those initial cycles, which I think are key for efficacy. And then the other thing that I want to point out is, in particular, the ADCs that have a deruxtecan backbone, like trastuzumab deruxtecan, we're seeing really high rates of ILD, right, north of 20% in some studies. And so to have a drug that does not have really any, to this data cut, reported instances of ILD, I think that is really important because patients are coming off osimertinib, they're coming off immunotherapy, and have prior radiation, and so this is a pneumonitis risky population, and that also kind of bodes well for potential combinations, because I think when we've combined like PD-1 inhibitors with osimertinib, we saw synergy with ILD, and so I think that to not have it with iza-bren really puts you in a good place for potential combos.
Sure, great points. Ignatius, I also know that UCI, you enroll a number of patients with iza-bren. Be interested in your experience with iza-bren and how you might manage those side effects.
I completely agree with Dr. Yu. The myelosuppression is actually pretty striking for an ADC, but this is the only side effects that we have seen. And I think I've emailed you to try to get prophylactic G-CSF starting on cycle 1. We do it in California, we just do it to everybody who is not on trial just to give the Neulasta. So that's actually very good now that you have. It's one of the easiest to manage side effects of myelosuppression. I think Dr. Yu has not mentioned a thing about EGFR. One of the questions people may ask is, do you get rash on that? We have cetuximab and all that, and actually it was very surprising. You don't get rash. The only side effects is myelosuppression, and now it can be mitigated easily with G-CSF support. And I think Dr. Yu also mentioned about deruxtecan, that there is maybe something unique about deruxtecan that it can cause ILD. Dapto-DXT is about, I don't remember, 3 to 6% ILD. But if you look at the trastuzumab deruxtecan, it's, the DESTINY-Lung02 using the lower dose of 5.4 milligrams per kilogram, their report is 15.9%, 15.9% ILD. We actually is part of an editorial on a JTO. The DESTINY-Lung02 study has come out, but we wrote an editorial, and we were questioning at that time when they were submitted to the FDA, the ILD percentage was 6% because it was from the FDA summary. But now, if longer follow-up, you get to the point of 15.9% at the dose that they chose. A lot of presentation, they just say, well, the lower dose is more tolerable. That's why it was chosen 5.4 instead of 6.4. But if you look at the actual data, 15.9% ILD is actually very high. And a lot of them are grade 2, which means it's symptomatic. You need treatment. And so with no ILD is very important. Myelosuppression was actually pretty traumatic, but it's easily manageable. I mean, that's one of the things. And no rash too, because you anticipate an EGFR antibody base, you may have a rash, and it's actually, so I agree with Dr. Yu, it's easily combinable, and it's very tolerable, and hopefully in the future, you will be optimize the dosing, and also maybe even, and all that, yeah.
Sure. No, I appreciate that. Thank you for your points. And also, we did email back saying we are moving to a profile. So we listened to our investigators and learn from it as we kind of move forward the program. Yeah, and I think the rash is an important question. I do think that speaks potentially to bispecific biology, because you can target antibody with a bispecific close to the tumor a little bit more than the skin, which probably doesn't have a lot of HER3. So the therapeutic index can be increased. So maybe that's an example of maybe some of the unique natures of a bispecific. I do want to close out this session, and thank you to my distinguished colleagues and guests, by asking a future-looking question. So, we know that iza-bren has been presented in a number of congresses, a number of forums, showing activity because it's an EGFR specific across a wide range of cancers, not just lung cancer, but also breast cancer, small cell, bladder, biliary, esophageal. So the list is long because it's an EGFR bispecific. So as a clinical drug developer, David, I'd be interested in what you think is the opportunity, how to think about kind of emerging robust clinical activity as we continue to learn more about iza-bren. How do you view that?
We do see iza-bren as an opportunity to develop a novel therapeutic approach, or a novel ADC that targets EGFR expressing malignancies across multiple solid tumors. I mean, the breadth and the depth of the responses that we have seen come to confirm the potential that this drug has to generate deep responses and to show a clinical benefit that might be applied across indications. I mean, today we've presented the data, in a multi-tumor cohort, but with a focus on non-small cell lung cancer, both EGFR mutant and wild type. But as John said, there have been multiple data sets published by our colleagues in China from Biok in cholangiocarcinoma, ovarian, esophageal, and those responses are encouraging and compelling. And of course, BMS with our colleagues from SystImmune are committed to further evaluating this drug, to continuing to bring this drug to as many patients as possible, and hopefully, as I said before, changing the treatment landscape and the potential standard of care in certain settings.
Sure. And then Helena, I'll let you get the last word. Thank you again for your presentation. EGFR target in a bispecific, I know you're a lung cancer specialist, but even within lung cancer, different lines of therapy as well as outside, just how do you think about the potential of an EGFR bispecific ADC, which I think is a little bit unique in the field right now?
Yeah, I think David's job is challenging because for each kind of solid tumor, you need to be thinking about what else is in the field, what are the possible combination therapies. I know people are interested in ADCs with immunotherapy, ADCs with targeted therapy, and so I think it's, as drug developers, you want to meet the unmet needs, right? So I think where can we do better for our patients? I think in lung cancer, I think we need some ADCs approved for all comers, and so that for all non-small cell lung cancer, which this might be a potential indication. And then I think for EGFR mutant lung cancer, I'm obviously intrigued with the combination with osimertinib, right? Can we, by targeting the kind of oncogene driver and then adding in this ADC, can there be synergy and sort of enhanced efficacy? So.
Sure, great. I do want to say all of our jobs are a little bit challenging, but it's for the benefit of patients to give them more options to improve outcome. Lung cancer, metastatic disease is unfortunately a tough disease, and anything we can do to help patients and their families, we obviously will continue to do all day, every day as much as we can. So I appreciate everyone's efforts, the partnership with clinical trials, and the community it takes to do clinical research. I appreciate the audience. I'm going to bring the session to a close by thanking the audience for your attention. We hope it was educational and helpful to understand the latest data come from ESMO. And with that, I wish everyone a good evening.